Hello, everyone. Today we are going to talk about the resuscitation in the neonatal intensive care unit. As you guys are very well aware that the new edition of NRP, the ninth edition is out, and chapter 16 is all about the resuscitation in the NICU. So far, we know that NRP is basically, corresponds to the delivery room resuscitation. But now they are extending it to the NICU, which is very important for us to know, because most of us, those who are involved in NICU care, they know that NRP principles essentially does apply, but there are certain minor changes that one has to be aware. So first of all, there will be a course coming in online on the learning site for the NRP. So that course will be available pretty soon. So we all should do that. So this is just a brief review of chapter 16, and we'll present some cases for interaction so that we know that how NICU environment is different than delivery room and different than total PALS, because PALS extends from an infant to really pediatric group and even young adults. While neonatal resuscitation is basically in an infant less than a month. So there will be some overlap. Anyway, too much of intro now. Let's jump into the presentation. So these are the four components which, the differences has to be known that, of course, the NRP versus PALS. We'll talk about it later, that what are the difference. Then, of course, the resuscitation should not depend upon the age of the newborn infant. It should be based on the etiology of the condition, which we'll talk about further slide. And again, the compression, we should still stick to 3:1 rather than following the PALS, because in newborn infant, it's rarely a cardiac anomaly or cardiac problem which really leads to the resuscitation requirement. And again, cardioversion and defibrillator are really not the prime interventions needed in NICU as compared to PICU or pediatric population or pediatric ward. And we are going to touch again by giving some examples. So here is case one. So this is an infant who was born at 23 weeks, now 17 weeks old. So the post-menstrual age is 40 weeks. The infant developed bronchopulmonary dysplasia and tracheobronchomalacia and pulmonary hypertension. So this is the history. So what happened? At around 2 a.m., the infant had an acute onset of desaturation and bradycardia. So respiratory therapist, neonatal nurse practitioner, and the fellow were called at the bedside by the registered nurse. So from now on, we just use the abbreviation in the other examples. Anyway, so this is the condition. So like this is the NICU scenario, and this baby is acutely deteriorating. So what they did, so RT changed the saturation probe, increased the PEEP, and decreased the rate. And the baby is on a nasal IMV. It's not given there, but that's what we assume, because it was not mentioned if the baby was intubated. Anyway, and NNP started to look for the heart sounds and breath sounds, and the fellow prepares for interosseous, because if this need to be need for medication, and so that's the case. So how it progresses, the respiratory therapist check for dope, and we'll talk about what is dope, but essentially is displacement of the tube or the prongs, obstruction of the respiratory tract, pneumothorax, or extubation if the baby is intubated. But like we said, it's not mentioned here. We assume that baby is on nasal IMV. So on examination, of course, one has to rule out sepsis, shock, because these are very common scenario in NICU. And fellow is preparing for line, just in case if we need to do medication or do fluid resuscitation. So NIV was paused. The positive pressure were provided with the T-piece. The blood gas, chest X-ray, and point of care was done. Point of care ultrasound was done. So chest X-ray showed white out. There was no pneumothorax, so that's reassuring. The PEEP was increased a little bit. The blood gas showed a pH of 7.2. That was also acceptable. So NIPPV settings were adjusted, and a spot dose of furosemide was ordered. And point of care showed good contractility of the heart, and it showed Brovic in place. So here the thing we have to learn, that we have to know our environment, because fellow was called at the bedside, and maybe he or she was not aware about the details of the condition, and patient already has a Broviac. Actually, this has happened to one of our colleague, that he was not covering NICU, but he was in the core team, and he was about to do an interosseous, and then one bright intern stop and say that baby has a Broviac. So why you want to do the lines? So just be aware of your environment. The central lines are usually in place in NICU babies, so you don't have to do interosseous. Similarly with NRP, we rarely have to do interosseous. Usually we get the umbilical venous catheter in for medications or fluid resuscitation. So just a small learning curve as compared to PALS or pediatric resuscitation. Anyway, in this condition, what was found that the nasal prong was really dislodged. So it was, like we said, dope or displacement is the first thing that was the cause of it. So see, like in this case, we all know that you don't have to really do the cascade of resuscitation as you do in NRP or PALS, because ultimately the baby just has a dislodged prong. So this baby was saved from a needle aspiration, chest tube, and interosseous line just by vigilant care. So again, teamwork. So now let's go to case 2. See what is the case 2 is. So this is an infant who was born at 28 weeks, now 4 days old. She is in the NICU. The umbilical, arterial, and venous catheters are in place. So we are going to use this abbreviation in the follow-up slides. And the patient is on nasal CPAP, total parenteral nutrition, and trophic feeds. So this is the condition. So what happened with this baby? So the nurse notes that there is an acute desaturation. The saturation was down to 65 and heart rate down to 50. So the team was called at the bedside by the charge nurse, and the RT changes the probe, orders chest X-ray stat. NNP examined for the breath sound, started the chest compression because the heart rate is less than 60. So this is an indication for chest compression. And the fellow ordered the fluid bolus and perform a quick point of care ultrasound evaluation, because this is an acute deterioration with the baby lying in situ. So here there is no need, as you notice, that nobody was worried about the vascular access because it's already there. So what happened? Chest X-ray showed no pneumothorax, so that's reassuring. But the point of care showed a pericardial effusion, and the umbilical venous catheter was malpositioned. So respiratory therapist performed the intubation, the NNP removes the UVC, and fellow performed the pericardial synthesis under the ultrasound guidance, and baby responded very well to it. So the second case showed that this is a pericardial effusion, and again, like we said, the NICU resuscitation is etiology based and it's not age based. So this baby was only 4 days old, but the etiology was entirely different, and that's what taken care of. So again, teamwork. Now let's go to case 3. So in case 3, this is an infant who was born at 26 weeks of gestation and now 16 days old. He's in the NICU. The lines are in place, and he's on CPAP and TPN and feeds. So what happened with this baby? The bedside nurse notes that it's a sudden deterioration in bradycardia. So team was called at the bedside. The RT checks the probe, making sure that everything is okay. The NNP examines and notices a distended and discolored abdomen. The fellow ordered the chest X-ray and called the pediatric surgery to the bedside. So the X-ray showed pneumoperitoneum. So RT intubates the infant, placed on the ventilator. The NNP ordered the labs and antibiotics, and the fellow scrubs with pediatrics to look, maybe he or she can learn about the parenthesis and drain placement. So the spontaneous intestinal perforation was noted on the exploratory laparotomy. So this case again points out to that in NICU, the etiology really triggers the bradycardia and desaturation. Usually it's the pathology rather than the cardiac condition where you have to really do the acute resuscitation. So focus on the etiology as per case by case. So again, nice teamwork here. Now case 4. So this is an infant who was born at 32 weeks gestation and now 3 days old. He's in the NICU. The lines are in place and on CPAP, TPN, and trophic feeds. The nurse noted acute, onset of tachycardia. The monitor is showing heart rate of 40 beats per minute. The team was called at the bedside. The respiratory therapist, checked the saturation probe. The ECG leads were checked. Chest X-ray was ordered. The NNP examined the baby, ordered the 12-lead EKG on the bedside, and fellow prepared for medication and asked for defibrillator at the bedside. The chest X-ray showed that the UVC was in the right atrium, and ECG was confirmatory of SVT, supraventricular tachycardia. The FiO2 was increased, the UVC was pulled back, and after placing the eyes to the face, this baby responded very well. The second line would be adenosine and then synchronized cardioversion, depending upon how stable the baby is. At this point, I want to mention that tachyarrhythmias are again common in NICU, but again the pathology is usually different than in PALS. So here you can follow the PALS algorithm for tachyarrhythmias because they have a different category. They have narrow complex, wide complex, they have a stable, unstable, then they have cardioversion versus defibrillator. And again, you just have to know that. But like I said, most of the cases do respond to isonthafase and adenosine. We rarely has to do cardioversion, and very, very rarely if we have pulseless tachycardia, which is again very, very rare in NICU, where we have to follow the PALS algorithm. So again, nice teamwork. So let's summarize. So basically, whenever the code is called in NICU, code called means that there is a need for acute resuscitation, and if the newborn infant is showing deterioration, sudden deterioration, so that is like a code is called. Of course, three components has to be met. One is a detailed quick examination, some investigations, and of course certain procedures. So in examination, journal examination, if there is signs of shock, capillary refill, the color of the baby, how the baby is doing. Chest, of course, look for the breath sound bilateral. If the patient is intubated, make sure the tube is intact. Cardiology, make sure that you hear a good heart sound with no murmur or any other signs of the abdomen, like we saw in the previous case. That look at for discoloration, distension, and of course neurological examination is important if the patient is having any seizures or any other problems there. Investigation, blood gas is a very good investigation to get because most of the auto analyzer these days give you electrolytes and hematocrit and hemoglobin, in addition to provide you with the gas parameter. Chest x-ray is very important because that can tell you about, like we saw in the cases, pneumothorax, it can show pneumoperitoneum, it can show other findings. Echo is important. If you have a skilled person available, echo is great, but point of care ultrasound is very good thing to have. And most of the younger fellows are going through the point of care ultrasound training, and they know how to do the point of care ultrasound, which we saw in previous case, that how a fellow really diagnosed the pericardial effusion and saved the baby from severity of cardiac tamponade by performing the POCAS in time and draining that fluid. And of course, the CBC, CMP, and blood culture, like I said, etiology based. If you are suspecting a baby having an infection, of course, getting a CBC and blood culture is very important. So certain procedures that are given in NICU, intubation, thoracocentesis, pericardiocentesis is really not that common, and also peritoneal centesis is not very common. Usually surgery does it, and pericardial, usually people have pediatric cardiology. Always call pediatric cardiology. Most of the hospitals do have 24/7 coverage of the pediatric cardiology, and they're expert in doing this procedure. If there is time, wait for them. Otherwise, like we saw in the case, that one has to do it. And the new book, the 9th edition, has certain pictures. So if you buy that, look at the pictures, how to do the pericardial centesis. Very, very simple, but again, it's an important procedure that can save life. And of course, cardioversion and defibrillator, again, like I said, it's not very common in NICU, but again, one has to know it in case of tachyarrhythmias. If they become unstable, then defibrillator and cardioversion can really save the babies. And of course, medications. Certain medications are important. Fortunately, in NICU, the medication range is not long as compared to PALS, because their algorithm even go to other cardiac medication. But in newborn, usually epinephrine, adenosine, and saline bolus. We rarely use other cardiotonics drug in acute resuscitation. Chronically, we do use vasopressor and all, but in acute resuscitation, we don't go beyond certain drugs. So again, going back to etiology, dope, again, remember the mnemonic. If an acute deterioration in any baby who's intubated or on CPAP or on a prong, always make sure that it's not dislodged, it's not obstructed, there's no pneumothorax, and if the patient is intubated, the patient is not extubated accidentally. Airway, make sure that airway is intact. Sometimes the baby's neck is bent and the airway is blocked. So just by opening and making a sniffing position, the airway opens up. Some newborn babies have laryngomalacia, so they can obstruct their breathings, just by lying, supine. Further, they can have adenoid problems, arytenoid problems, and their airway collapses, and they could have tracheomalacia as well. So this is another thing. Lungs have a lot of pathologies, and the most important is pneumothorax, because pneumothorax can cause acute deterioration. And again, pneumonia and meconium aspiration and other infections and fluid, all that can manifest as a problem, but acute deterioration is usually due to pneumothorax. Remember that. Cardiac conditions, cardiogenic shock, sudden closure of a PDA in a PDA dependent lesion. There is a separate cardiac course offered by the current NRP, and it's available on the web. If you guys have time, please do that. There is a separate video we made on that topic. If you scroll down the list, you will find that. Of course, abdominal examination, as we talked about in a case of spontaneous perforation. Neuro examination is very important because etiology is different. If the patient is seizing, then the etiology is different and you have to do a different resuscitation. And of course, shock. Shock could be septic shock, could be distributive shock. We'll talk about it in a minute. So the mnemonic which we use is the Dr. Shock is the chair and the head of the department. So shock are of 4 types: cardiogenic, hypovolemic, obstructive, and distributive. Again, the purpose of this talk is not about talking in detail about shock, but basic idea which we want to throw is that NICU resuscitation depend upon the etiology, what is causing it. Just remember that. So in summary, let's go box by box. So of course, the first one which we talk about, that NRP is ABC, airway is NRP, while PALS is circulation first. So that's the main difference between NRP and PALS. And again, like we said, we don't go by age. If a patient is 36 days old, it's almost a month, and in NICU, we probably will follow the NRP rather than PALS. And again, we think that airway is most of the problem rather than circulation. Again, vascular access, as you remember in NRP, umbilical venous catheter is usually the port of access, as compared to PALS, where interosseous insertion take precedence over other lines. And like we saw in a case where the fellow was about to do the interosseous, but there was a Broviac present already. So just make sure that if vascular access is available, it's very important in resuscitation. Procedures, certain procedures are really very important. Intubation, chest tube insertion, these are the 2 major ones because that can save the baby. The rest we talked about already, could be done by experts like pericardial centesis or peritoneal centesis by the surgeons. What about tachyarrhythmias? Tachyarrhythmias and pulseless electronic activity. Like I said, pulseless electric activity is not very common in newborn nurseries or NICUs. It's common in pediatric population. But again, one has to be aware about that. And we talked about already that medications are very limited in NICU use as compared to PALS. So in conclusion, we talked about, that NRP still is NRP. Neonates are still neonates, and they are small infants. So NRP basic principles should be followed in NICU as well. So please do read chapter 16. If you have access to the ebook, you can have the access right away. Otherwise, the book is launched and it will be mailed pretty soon, and they will be having a separate course on the learning website. So please look out for that. So I hope you guys have enjoyed the video and learned something together. So please do like and subscribe to our channel, and you guys have a wonderful day. Bye.